Shukran, Ustaz Amira. What I want to do in the next few minutes is just to spotlight dawning of the new era. Our agenda is what is new in 2020. As we all know, it's early diagnosis and very early diagnosis because there is no treatment to date to systemic sclerosis. We have quite a lot of advances in the etiopathogenesis of systemic sclerosis. We've got a lot of early screening algorithms for systemic sclerosis and some advancements in the management of systemic sclerosis, particularly in the area of interstitial lung disease and pulmonary artery hypertension. But as we all know, yet no cure to date. Systemic sclerosis is an orphan disease. The onset typically occurs in middle age, 30 to 60, 4 times commoner in women. It remains one of the deadliest diseases, and despite decades of research, it's lacking a lot behind rheumatoid arthritis and other inflammatory diseases. Only one disease-modifying anti-rheumatic drug, has been approved. It's not even an anti-rheumatic for severe lung complications, as we all know, and of course, no other effective treatment exists to date. Little therapeutic process, as with many other rheumatic and musculoskeletal conditions. Why is the clinical heterogeneity of systemic sclerosis? It presents a major clinical challenge to us, and not only to us as clinicians, also to researchers in designing clinical trials for the drugs of these for this disease. So, as we all know, in clinical practice, mainly we say there are 2 main subsets of the disease: the diffuse cutaneous systemic sclerosis and the limited cutaneous systemic sclerosis. But actually, as we see, there's a substantial clinical variability going on. And indeed, the heterogeneity of this disease is one of the causes why we are not progressing in therapeutic agents. Lately, and of course, if we wanted to progress even further, we are going to need to stratify our patients better. And we need more robust, more composite outcome measures in order to stratify our patients. As I said, the recent success that we have seen is a drug that we've taken from the idiopathic interstitial pulmonary disease, and this was notably seen in the studies, the census trial of patients where the tyrosine kinase inhibitor nintedanib was shown to reduce a decline in the forced vital capacity, and this led to its being introduced by the FDA in 2019. Another milestone in interstitial-related interstitial lung disease was the 2020 publication of the first evidence-based expert consensus statements for its identification and management, which stressed the importance of screening all of our patients with systemic sclerosis for interstitial lung disease using high-resolution CT and the need to use multiple measures of disease activity, not to wait until symptoms occur. So we have great steps forward, a robust pipeline of promising small molecules. Every day we read about new studies coming out, promising small molecules, biological agents, acting on diverse targets, also targeting inflammatory fibrotic pathways, as well as vascular pathways, as well as epigenetics, metabolism, and the cellular senescence. But yet, as we know, it's one of those difficult to treat and most challenging diseases. Rare connective tissue disease, the pathologies and the pathogenesis is well known to all of us: excessive fibrous tissue deposition, generalized vasculopathy, and of course, autoimmune aberration. So to date, we are still disappointed. It's an uncurable disease, even though a lot of steps have been made knowing the pathogenesis, and we all know that's an interplay between genetic factors, epigenetic modifications, environmental exposures leading to alterations in the vascular and immune systems. Indeed, disappointments have outnumbered the successes, as we all know, because, as I said, the heterogeneity in the trials. Barriers are known to all of us, barriers in diagnosing. Early detection is needed. we need to be, other than rheumatologists, primary care physicians need to be aware about the early symptoms of scleroderma or systemic sclerosis. And of course, we have the mimickers. So this is what is taking us back. This is the classical classification, the teaching classification that we have. We all know it. But we know that there's a lot of heterogeneity. There's many faces to systemic sclerosis, many autoantibodies. There's a lot of overlap between the limited and the cutaneous. It's not distinct to subsets. The major subsets are what we know, what we are confronted with, but there's a lot of gray zone. We do rely on the autoantibodies because we say sometimes when we find a certain antibody, such as the RNA polymerase, that's more towards renal affection, and we take care of the blood pressure, etc. Centromere antibody, more towards pulmonary artery hypertension. Other antibodies towards progressive interstitial lung disease. But what is going on now? They are driving towards a new classification of systemic sclerosis. The U-STAR cohort has started this, and they have initiated this, and they have identified 6 subsets of systemic sclerosis, as opposed to what we have as the binary classification of limited and cutaneous. And they are moving closer towards getting a new classification. And once we get this new classification, more stratification, more improved care and trial design. We also read of the studies that are coming up. This was the new study that we read pertaining to what I've just mentioned. This was a study looking at the phenotypes determined by cluster analysis and the survival in the prospective U-STAR and research cohorts, very large cohorts. And the findings suggest that restricting the subsets of systemic sclerosis patients to only those with limited or only based on cutaneous may not capture the complete heterogeneity of the disease. Organ damage, antibody profile should be taken into consideration when looking and investigating the individual patients. So this study concluded that systemic sclerosis, as we know, is a heterogeneous condition. There's a consensus regarding the relevance and practicality of the subclassification. The binary classification will omit a large proportion of patients. We will miss a lot of phenotypes, and therefore there is an increasing demand for a future classification which will be more phenotype oriented. These are the 6 clusters that they determined. Cluster 1, patients having a highest percentage, being female as having the female sex being the highest percentage, older age, they were all clustered in one group, high rate of GI involvement, lowest proportion of interstitial. So that's one cluster on its own. A large amount of patients were clustered. Another cluster, as you see, high proportion of interstitial, high rate of suspected pulmonary artery, lowest proportion of joint. And so if we can sort of subdivide our patients, this may lead to better clinical outcomes, better diagnosis, and longer survival rates. So the clustering has made them move into more actionable subsets, and more recently, high throughput technologies, as we will be hearing later on in the symposium, in the Congress by Dr. Naveen. She will be telling us about this. This will really put us forward, and we will get more and more subsets and better phenotypes of our patients. Something which is also so important is, of course, the treatment. We know the treatment. We all know the 3 pillars that we have: immunosuppression, vascular dilatory, vasoactive treatments for pulmonary artery hypertension. But what we need to do, and what we are all doing in clinical practice, is the combination, particularly combination for pulmonary artery hypertension. Combination therapies are coming in. So, and of course, as I said in the beginning of the lecture, now we're having more targeted therapies, targeted towards the cytokines that have been implicated, the co-stimulatory molecules. So we need an early diagnosis. Diagnosing our patients in this state, that's too late. The complications are there. So we need not only early, we need very early diagnosis of systemic sclerosis. This will create our window of opportunity here. And this will provide the potential to slow or stop the progression of the disease, because we know no currently effective DMARD can stop this progression of the disease. It's a very active, progressively disease. The old name says progressive systemic sclerosis. Red flags that we all consider and all look at, of course, are the puffy fingers, the Raynaud's phenomenon, and of course the positive anti-nuclear antibodies. But of course, now, as we know, that's the suspicion. We move on to the other levels, the capillaroscopy, and how the capillaroscopy is helping us move forward. And if either one of these is positive, we can diagnose very early systemic sclerosis and ask for further investigations. And then we have our third level, early systemic sclerosis. So many studies have looked at diagnosing very, very early systemic sclerosis. And of course, the puffy fingers should raise the suspicion, as we all know, as 40% of ANA positive Raynaud phenomenon patients with current or previous puffy fingers moved on to have full-blown systemic sclerosis. So the challenge is to early diagnose our patient, to create this window of opportunity, to diagnose early, to get better classifications. The EULAR 2013 hasn't fulfilled our expectations. It doesn't tell us about the clinical outcomes. It doesn't take us one step further. It has taken us quite steps further, but we cannot go right further. We should predict early back, the silent phase, as Professor Ragar was telling us, preclinical RA, that's even before early rheumatoid arthritis, because we know once it's established, prognosis is very, very rapid, particularly the interstitial lung disease. And it's one of the devastating causes of death, as we all know. Progress has been made. But what's very interesting is, as I said, again, defining the subset, the phenotype of the patient. If we have the phenotype by autoantibodies, by getting better classification criteria, we can pick up, as you see, these overlapping circles. To whom will we prescribe early the treatments for pulmonary arterial hypertension? To whom will we prescribe this is what we are needing. We're needing a better classification. We've got a big array of drugs across the symptomatology, Raynaud's phenomenon, digital ulcers, pulmonary arterial hypertension. As I said, we are going to and driving towards combination therapy now. Combination therapy is what we will be using there. A big array of drugs. The biological agents have come in as well. Professor Mohammed, you have to realize biologics are here to stay. So we have to do the cost-effective. Biologics are here to stay across the spectrum of inflammatory rheumatic diseases. As you see, the studies and the clinical trials are going on. Very recently, just maybe 2 days or 3 days ago, we had this new study coming out, a proof of concept study looking at ramucirumab. This is targeting the interleukin-4, interleukin-13, the two cytokines that have been recently implicated. So it's a humanized monoclonal antibody targeting this. And how might this impact the practice? This is a first study to highlight the potential of such a drug in diffuse systemic sclerosis and providing a proof of concept, providing the platform for more phase studies. So this is the integrated view we're going to be having in the future of the systemic sclerosis phenome, not only the clinical, but the high throughput molecular, the omics, as we say. And this, together with the integrated for informatics, this is not in the past, present. This is going to be happening in the next decade across the world, even in countries such as ours. We know that the standardization of the nail fold capillaroscopy has become very important, and use of the nail fold capillaroscopy is important. Articles are published exponentially in this area. We know now we have the fast track algorithm, how to differentiate between a scleroderma pattern from a non-scleroderma pattern, even though I still believe that this needs expertise and it needs a lot of training. But now we have at least the studies to show us that this can be very helpful across the board, early, active, etc. This very nice study picks up on this. Nail fold video capillaroscopy in systemic sclerosis, how can it be a guide or a proxy for us to pick up pulmonary arterial hypertension? So the group by Vanessa Smith looked at this point, and they picked up that by doing nail fold capillaroscopy, it can be a predictor for pulmonary arterial hypertension or a proxy for lung involvement. So a non-invasive test picks up something else. So this is very, very encouraging. The treatment options are increasing. We didn't dream of something like this. This wasn't. Now we have, as I said, a lot of options. We can combine the options, but we have to think of pathophysiological clusters. 3 distinct clusters are showing up: the vascular phenotype, the follicular T helper phenotype and the T helper 17 phenotype. These are the phenotypes that have come up. So the drugs, what will work in the vascular phenotype will not work in the follicular T helper phenotype. So this is where we can stratify our treatments. Factors associated with pulmonary hypertension have been further elucidated, and now we all know that the risk factors that we should look in all of our patients are older age, and autoantibodies, longer disease duration, limited cutaneous, the longer disease duration, the limited cutaneous subtype, and the presence of may also, as I said, there's a gap. So the presence of the interstitial lung disease may enrich us as well. And we, as I said, we will pick up early patients. And of course, this will be by picking up and stratifying our patients. So the window of opportunity exists. There are many steps in identification of the pre-scleroderma. The broad steps, very nice initiation in the stem cells. Also, stem cells is very effective. As I said, there's a new drug out for interstitial lung disease. Very nice results for this drug. Nail fold capillaroscopy can be a proxy. We all know how to proceed with pulmonary hypertension. I won't proceed for that. As I said, mortality and the lead cause of across the board. If you look in the early 90s, up to now, it's still interstitial lung disease. But this is going to be picked up early by the mapping and the predicting of the mortality. So this was very nicely seen in this study. For the sake of time, I'll run over it. Screening is important. The prevalence is well known to all of us. As they've published, interstitial lung disease appears early on in the course of the disease. We should have a very high level of suspicion for this. We've got very nice consensus now, well known to all of us, how we screen, how we look for the risk factors. This all goes back to us discovering more and more about the etiopathogenesis. Very nice studies looking at all of these different steps. Progressive interstitial lung disease, as I said previously, is occurring in most of our patients, but if picked up early, so we've got a lot of drugs out there, drugs that we know, new drugs that will be coming out and targeting the fibrosis. Things don't look as bad as they used to, but we still have some way to go. Combination treatment is going to be upfront. Genomic risk scores are going to give us a lot of details. Mapping is very important. We still have a challenge. We still have a challenge because we are still not there. But there's a lot of hope. Hope shines out, but there's still a long way to go. A lot of hope with stem cell transplantation. A lot of hope with picking up interstitial lung disease. We have to diagnose early, to treat irreversible early, and we, in this way, can improve survival. But as I said, we've got a room for a lot of improvement. Thank you so much for your attention.